Whenever we have a patient with monoclonal protein, we want to make sure that the patient has multiple myeloma or not, so we undergo a laboratory evaluation which include complete blood counts, biochemical survey, skeletal survey, and bone evaluation of the bone marrow. Whenever we detect bone marrow monoclonal plasma cells, this patient has a systemic disease called multiple myeloma. And whenever we detect also lytic lesions, we want to further evaluate these patients with more delicate and refined exams, such as CT scans, MRI, as indicated.
To diagnose a case of multiple myeloma, you have to find a monoclonal band in the blood, plasma protein electrophoresis. You have to check the free light chains in serum and in urine. And of course, you have to do a bone marrow to check for plasma cells in the bone marrow, if they are less than or equal or more than 30%. However, this is not only the case. You have to check the renal functions, creatinine. You have to check the bones, if there is any involvement. You have to check for anemia. You have to check if the patient can withstand the medications that you are giving. So, for example, if there is a neurological problem, then some of the novel agents have to be avoided. Of course, you need to check the serum calcium if it is high, because this can be also a manifestation of the side effects of multiple myeloma.
Usually, for asymptomatic patients with multiple myeloma, we do not initiate treatment until we have some evidence of disease progression. Thus, asymptomatic patients, regardless of age, should be followed closely without preemptive therapy, unless they are being included in a clinical trial. For young symptomatic patients with multiple myeloma, the standard of care today is a bortezomib dexamethasone containing combination with the addition of thalidomide, of cyclophosphamide, or of doxorubicin in most parts of the world for 4 courses. These regimens, they may induce responses in the overwhelming majority of the patients and allow us to collect stem cells and then to proceed to high-dose melphalan supported by the stem cells that were previously collected. This is the standard approach for a younger patient with multiple myeloma without comorbidities.
Symptomatic patients and that are young should be treated aggressively by a combination of novel agents, preferably a triple combination including corticosteroids too. And then as soon as they give a good response, they have to be channeled into transplantation. With asymptomatic patients, well, this is really new, because before, asymptomatic patients used to be just followed up. But these days, there have been thoughts of even treating asymptomatic patients, especially if they are young.
The progression-free survival after frontline therapy is usually longer than the progression-free survival after the patient experiences a relapse. And also we know that with each subsequent relapse, the period that the patient remains without progression is shorter and shorter. Thus, it is important to try to prolong the first progression-free survival and also to develop effective regimens that could be given as a second-line treatment and thus also improve the second progression-free survival.
Progression-free survival in cases that are relapsed after novel agents is not very optimistic. The progression-free survival is very short. And you try to give a medication that has not been given before. If you have started with IMiDs, then you go for bortezomib. And it's the other way around. If you started with both, then the choice of medications is narrowing.
unless there is a real rapid increase of the monoclonal protein, or unless the patient had an initial presentation which put him at risk if this occurs again at the time of relapse, such as renal failure. For the majority of the patients, we follow them closely and we initiate treatment when we see some evidence of increasing creatinine, decreasing hemoglobin, or any new bone lesions, or increasing pre-existing bone lesions. For patients with symptomatic relapse, of course, immediate treatment is initiated, and the treatment decisions will be based upon several factors, including prior regimens, response to prior therapies, duration of response to prior therapies, pre-existing toxicities which will affect the choice of the treatment that will make, comorbidities, etc. In my opinion and in my experience, treatment with calfizomib is well tolerated in the overwhelming majority of the patients. The shortness of breath adverse events can be prevented or treated by reducing the amount of fluid that the patient is getting and by monitoring the patient closely, by treating his hypertension. And we have not experienced significant problems with renal function. Neutropenia and thrombocytopenia is minor and readily reversible with the administration of growth factors. Overall, it is a very well tolerated treatment.
A biochemical relapse is an increase in the M component on a plasma protein electrophoresis without clinical manifestation, as in no affection in the calcium level, no affection of creatinine, no affection of bone disease, and no affection of blood, for example, no anemia. It's just a biochemical reading rather than a clinical manifestation. However, even biochemical relapses are being considered for treatment, so that you do not wait, or it is considered probably not to wait for a clinical relapse before restarting a medication.
With the data from the FOCUS trial, with the data from ASPIRE, with the data that we are collecting prospectively from the ENDEAVOR trial, where a fraction of patients will be prospectively followed with cardiomarkers and echocardiograms, we will have a complete picture regarding the true incidence of cardiac adverse events in patients treated with calfizomib. I believe that the data that we have with the ASPIRE are very reassuring that the incidence of cardiac adverse events are really low. I don't believe that today we have any factors that could predict the occasional patient that may experience a severe cardiac adverse event, but I would like to stress the fact that there is a remarkable improvement in the outcome of the myeloma in these patients, which clearly outweighs the risk of some very unusual cardiac adverse events which may occur.
In the ASPIRE trial, there have been reports of cardiovascular events that have happened to some of the patients. Of course, by mentioning cardiovascular events, it is a wide spectrum of events. However, you need to be careful with your patients that have had a cardiac problem before, and you need to be careful in monitoring your patients, and you need to refer your patient to a cardiologist, specifically if there is any sign of cardiovascular problems. If the patient has a past history, if the patient is being treated for a cardiovascular problem, of course this can pose an event that needs to be tackled. And you need to follow up the patient carefully, and you need the patient to be aware of the adverse events, just in case you need to refer to a cardiologist.